The next component in common blood investigations is comprehensive electrolyte panel, which contains calcium, protein, bilirubin, alkaline phosphatase, aspartate, and alanine transaminase. Now moving on to calcium. The normal blood calcium level is 9 to 11 mg per dl. And the few functions of calcium: in muscle, it mediates excitation and contraction of muscle fibers. Nerves, it helps in the transmission of nerve impulse from presynaptic to postsynaptic terminals. It monitors the secretion of hormones. Calcium cyclic AMP, they act as a second messenger in the systems involving G proteins. It helps in the vascular permeability, and this is the factor 4 in coagulation cascade pathway. It helps in the contraction of myocardial muscles, which prolongs the systole and helps in the development of bones and teeth. So what are the signs of hypocalcemia? It includes anorexia, nausea, vomiting, polyuria, polydipsia, confusion, depression, psychosis, altered sensorium. In bones, it causes osteoporosis, pathological fractures. The reason for renal stones, calcification, and pancreatitis. And what is the etiology of increased calcium level? It is due to hyperparathyroidism, multiple myeloma, Paget's disease, metastatic carcinoma of bone, thyrotoxicosis, Addison's disease, benign familial hypocalcemia, dehydration, and in bedridden patients with prolonged immobilization, tuberculosis, leprosy, and sarcoidosis, and a syndrome called milk alkali syndrome. And what are the drugs which causes increased calcium level? Thiazides, increased intake of vitamin D or vitamin A, increased calcium IV infusion, drugs like lithium, theophylline. And what's the management of hypocalcemia? The first and foremost step is to maintain adequate hydration. Drugs like furosemide given IV helps in the excretion of calcium. Steroids if the calcitriol level is more. And what are the causes of hypocalcemia? Deficiency of vitamin D, deficiency of parathyroid hormone, increase in calcitonin, deficiency of calcium, magnesium, when the pH level is more, hypoalbuminemia, signs and symptoms of hypocalcemia or muscular cramps, paresthesia, especially in fingers, neuromuscular irritability, conditions like tetany, which can be elicited by atrocious sign, seizures, bradycardia, prolonged QT interval in ECG, and how to treat hypocalcemia. Oral calcium with vitamin D supplementation is given. First, we should rule and manage the underlying cause. In case of tetany, patient needs IV infusion of calcium, 10 ml of 10% calcium gluconate over 10 minutes. So here we should remember calcium IV infusion should always be given very slowly. The next electrolyte is total protein and albumin. Normal total protein content in plasma is 6 to 8 gram per 100 ml. Plasma protein contains albumin, globulin, and fibrinogen. And let's talk about the most common plasma protein, albumin, and its normal level is 3.5 to 5 gram per dl. So we know albumin is synthesized in liver, so it is one of the liver function tests to estimate the level of albumin. And one of the most therapeutic use of albumin is human albumin is used to treat burns, hemorrhage, and shock. What are the causes of decreased albumin level? It is mainly synthesized in liver, so in conditions like cirrhosis, malnutrition, nephrotic syndrome, when there is albumin presence in urine called albuminuria, protein losing enteropathy, and albuminemia, which is a very rare condition. And the causes of hyperalbuminemia is mainly because of dehydration, that is severe volume contraction secondary to any fluid loss. Moving on to bilirubin. Normal plasma bilirubin level is 0.2 to 0.8 mg per dl. Let's see the normal value of conjugated and unconjugated. And conjugated is 0.2 to 0.6, whereas conjugated is only 0 to 0.2. So if the level increases more than just 1 mg per dl, it is a condition of hyperbilirubinemia. When it is between 1 and 2 mg per dl, so it is sign for the onset of latent jaundice. When it is more than 2 mg per dl, it elicits clinical signs of yellowish discoloration in sclera, conjunctiva, skin, and mucous membrane. Now, the causes of hyperbilirubinemia, it can be classified into congenital and acquired conditions. Under congenital, the syndrome is Crigler-Najjar syndrome. Here the main defect is because of the enzyme UDP glucuronyl transferase. It is most common in children where they present with more than 20 mg per dl of bilirubin, which results in kernicterus, and usually children die before the age of 2 years. Next condition is Gilbert's disease, and the defect is in the uptake of bilirubin. Next one is Dubin-Johnson syndrome, which is an autosomal recessive disorder. The bilirubin gets deposited in the liver, which is called as black liver jaundice. And the last one is Rota syndrome, which is also an autosomal recessive disorder. Here the defect is in the excretion of bilirubin. And the acquired conditions of physiological jaundice and breast milk jaundice. The other causes of hyperbilirubinemia are hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Under hemolytic jaundice, in children it is RH incompatibility or erythroblastosis fetalis, and increased bilirubin may cause kernicterus, and the treatment includes phototherapy, that is with blue light of 440 nanometer of wavelength. What does this phototherapy do? It isomerizes the insoluble bilirubin to soluble isomers, where it gets excreted in the urine. Whereas in adults, the hemolytic jaundice includes congenital spherocytosis, G6PD deficiency, autoimmune hemolytic anemias, and toxins like carbon tetrachloride. The common cause of hepatocellular jaundice is viral hepatitis. In case of obstructive jaundice, when there is obstruction in the biliary tree, no bile pigments are excreted in the gut, which imparts clay-colored faces. The next, electrolytes or alkaline phosphatase, aspartate transaminase, and alanine transaminase. Moving on to alkaline phosphatase, its normal serum level is 40 to 125 units per liter, which is produced by osteoblast cells in the bone. So, increase in alkaline phosphatase is usually associated with calcification process, and the main functions are in transport mechanisms. The normal level of aspartate aminotransferase is 8 to 20 units per liter. This is the marker of liver injury. In olden days, it was used as a marker of myocardial infarction. Later, which is replaced by troponins in ischemic heart disease. Normal serum level of alanine aminotransferase is 13 to 35 units per liter in males, 10 to 30 in females. It can go high up to 300 to 1000 units in case of any acute hepatitis. And normally both aspartate and alanine transaminase are increased in any kind of liver disease. But this alanine transaminase rise can be noticed several days before the clinical signs like the jaundice. And moderate rise in alanine transaminase can be seen in cirrhosis, hepatitis C, NASH, that is non-alcoholic steatohepatitis. Thank you.